Hi, everybody. I'm Martin King, and I'm here with Ron Chen and Dr. Wang, and we're going to talk about difficult cases in GU cancers. And so I'll just get started. Okay. So I just wanted to talk to you about a patient. This was a 63-year-old patient. He had favorable intermediate risk disease, so his PSA was 6.5. He had clinical T2C per the notes and Gleason 3+4 disease in 4 out of 12 cores, and they were all on the right. This patient elected to be treated with IMRT alone, and so we treated the patient to the prostate, and he also got 77.4 gray in 43 fractions. This was the plan, and this was from the outside, and you could see that it was pretty conformal dosing around the prostate, and the dose fall off to the rectum was pretty good. And the patient, he had some urinary urgency and frequency that was treated with Flomax, minimal bowel symptoms, but he tolerated the treatment pretty well. And this was what happened afterwards. So he was treated, between 2012 and 2013. By 2015 to 2016, his PSA went down to a nadir of 1.57. And that was the lowest point. And since then, the PSA has been slightly, going up. And at first, the increase was pretty gradual. But after about 2019, the increase started becoming, much more significant. And his doubling time was about 19.5 months. And he hit the PSA biochemical failure definition of nadir +2, about like October of this past year. And now we're just looking at a segment of the PSA curve. As his PSA was rising, especially since it around the area of nadir +2, he started to get additional workup. So he had an Axeman PET that showed that there was some signal maybe in the right part of the prostate, but they weren't really sure with Axeman. And then he got a PSMA PET, which really just showed that there was a tumor in the right posterior prostate. You could see it pretty clearly. And then this one ended up being confirmed on multiparametric MRI, and it was consistent. Then what happened was that the patient got a fusion biopsy as well as a standard biopsy. And it was a transperineal approach, so the cores were a little bit different. It looked at the right lateral, the posterior, the anterior, and then the left lateral, posterior, medial, and anterior. And what it showed was that there was Gleason 9 prostate cancer, but if you compared it to what it was on the PSMA PET scan, it was a little bit more extensive than what we thought. The PSMA PET really just showed disease in the right posterior prostate. That was kind of like, posterior medial, posterior lateral. In this particular case, there was disease that was detected at least from the anterior core, the contralateral left posterior medial core, and then we get a multiparametric MRI because, this patient was actually set up for focal therapy, and we saw that the tumor actually increased in size from about 1.1 to about 2.2 centimeters over the course of, over the course for about like 7 or 8 months. He had no other disease elsewhere, so we didn't have any regional disease, he didn't have any distant disease, it was just a locally recurrent disease. And so, here's my question. So you see a gentleman, he's got pretty good performance status, minimal toxicities from the prior course of radiation, he has pretty good urinary function with an IPSS of score of about 6, not on any urinary medications right now, early 70s. What would be the treatment options that you would consider? Would it be observation, where you just follow this? Would it be intermittent androgen deprivation therapy, which is probably the standard of care mostly throughout the United States? Would you consider prostate reirradiation? Consider just SBRT or brachytherapy? Would you combine that with intermittent ADT? Would you do HIFU or cryoablation or refer this patient to salvage prostatectomy? So this was This was one of the questions that we considered. I don't know if we have any information in terms of what people would do or select. If you can see this, maybe you can answer the questions in the iPhone. You didn't see it? Okay. Oh, okay. 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 Well, okay. So, so radio-recurrent prostate cancer, PSA doubling time of 19 months, biopsy-proven Gleason 9 disease that's more extensive than PET or MRI. And what we actually did was we treated him, so this kind of the questions again. So if you see any of the questions, you can feel free to kind of see what you would recommend. And this was actually what we ended up doing. So we did a combination of 6 months of ADT, and we did HDR salvage brachytherapy. The way that we do the brachytherapy is we treat the entire prostate to kind of a dose of around 70 gray. But we actually increase the dose to where the tumor is. And so we delineate the tumor based on the MRI as well as the PSMA PET scan. And we try to increase that to at least above 13 gray, which is about 90 to 100 gray. And so we do it 2 fractions 1 week apart. So we actually do 2 different plans, and I like to do it 2 fractions a week apart, just because if the patients really have a lot of side effects after the first fraction, you can really de-escalate the dose for the second fraction. I think that's critically important, at least in my experience. And so in this particular case for fraction 1, he got 10.9 gray. His rectum D.1 cc was less than prescription. It's, we usually like it less than 85% of prescriptions. His D.1 cc was less than 115% of prescription. And he got about 12.6 gray to the tumor, which was, we were pretty happy about, but we thought it could be a little bit better. One of the challenges was that his prostate really rested on the rectum, and so we were limited in terms of how much the rectal dose would get. Then we repeated everything for fraction 2, and what we saw was that his prostate actually swelled up a little bit. And actually, that was actually a good thing for us because we could put a lot more needles in the tumor, and we were able to get about 15.8 gray into the GTV, but still maintain the other metrics in terms of the prostate D90, rectum D.1 cc, and urethra D.1 cc. So in this particular case, we gave about 130 gray to the GTV, but we did treat the entire remaining parts of the prostate just because he had more extensive disease on the PET scan than on the PSM, more expensive disease on the biopsy than the PSMA PET scan or the multiparametric MRI. So in terms of the short-term follow-up, he had increased urinary frequency. We put him on tamsulosin. He had looser stools and fatigue, but he actually tolerated the treatment pretty well. And about 3 months later, he was pretty much back to kind of baseline, except for slightly more urinary urgency and frequency. And so, there's an increasing interest for reirradiation, and this is really largely driven by the incorporation or the increasing utilization of PSMA PET, where you can see locally recurrent disease. And it's estimated that about 30% of patients have a local-only component within their prostate after a biochemical recurrence. There's actually multiple studies, including one cooperative group, that have looked at the success of prostate reirradiation. And so RTOG 0526 had 100 patients treated with actually low-dose rate brachytherapy, and their late grade 3 toxicity was 14%, 5-year biochemical progression was about 68%. And so, it's actually pretty good, right? 80% of the patients were able to avoid grade 3 toxicity. But I think a lot of people are still concerned about it. I've had a couple of grade 3 toxicities, and I actually get pretty concerned as well. And so there's also been interest in terms of, maybe we can de-escalate things. And so you can treat with focal HDR or maybe focal SBRT. And actually, in the studies that have been done with focal treatments, the grade 3 toxicities are very low. It's probably less than 5%. And the biochemical control is actually quite good could be about 70 or 80% at 2 years. The question is it actually durable? We don't know that. There's still a lot of emerging data. But I think that my main point of showing this is that reirradiation can be safe for probably the majority of patients, and it can actually give patients some biochemical control so that they can avoid the side effects of intermittent or continuous ADT. And then these are just some considerations for reirradiation. What are the modalities you want to use? You can use LDR, you can use HDR, you can use SBRT. You can also do whole gland or focal treatment, or you can incorporate ADT. So these are my slides. And then, okay. Does anyone have any questions? Okay, all right, so we're gonna pass it on to Dr. Chen.
Thanks. Hello, everybody. So this is the second case. This is a patient, let me see if the mouse works. Good. This is a 72-year-old patient who has newly diagnosed prostate cancer, PSA 9.4. He has Gleason 10 on biopsy, and 10 out of 12 cores were positive. Clinical T2 disease. Prostate volume is 40 cc's. Past medical history is pretty healthy. Patient, 72-year-old, but hypertension, sleep apnea, but otherwise a very healthy patient. What I do nowadays when I see a high-risk patient is I usually would get a PSMA PET scan to stage the patient for high-risk disease. And for this patient, you can see that the PSMA actually showed an area on L2. So this patient has a single area of metastasis with Gleason 10 newly diagnosed prostate cancer. So oligometastatic disease. I'm going to ask what you would do to treat this patient. But before I do that, does anybody have any questions about this case? Anybody want any more information about this patient before we move on to treatment? I think it's a pretty straightforward patient with oligometastatic newly diagnosed prostate cancer. So in this case, I would like to know how you would treat this patient. And I don't know that the poll is working, so we can just use hands. So how would you treat this patient? Option A is hormone therapy. So you can use ADT. You might use ADT plus abiraterone based on some clinical trial data. Option B is hormone therapy plus prostate radiation. Option C would be to hormone therapy plus prostate radiation plus also treating the L2 with SBRT or some other treatment. So maybe we can just use a show of hands to see what you would do. How many people would choose option A? Is it going to work? I don't, yeah. You do? Oh, okay. Well then. Okay, well everybody would, most people would choose option C, and some people would choose option B, but nobody would choose A. Well, that's great. Thank you for participating in that. So I want to show some data, and I'm really glad that nobody chose A, because I think A is probably my least favorite option. So just to show some data, and we can move on to my slides. So I think there's a very strong reason to treat the prostate. I think probably the best data on this is from the Stampede randomized trial arm H. This is a trial that was published a couple years ago, but there was a recent update in 2022 for long-term outcomes of this trial. And I think as most people know, this is a trial for patients with newly diagnosed metastatic prostate cancer, a very large trial with 1,900 patients. And it was randomized to standard of care, which is hormone therapy, and some patients got docetaxel too. So systemic therapy versus systemic therapy plus prostate radiation. And the radiation that they allowed on this trial could either be, this is ultra hypofractionation, 36 gray and 6 fractions is almost an SBRT regimen. And so this is one of the options that they have for prostate radiation. They did it once a week, I think it's fine. Or I think the other option was moderate hypofractionation, 55 and 20 fractions. every day. And so I really think that if you believe that this trial is positive, I think these are two reasonable regimens, almost like an SBRT regimen and a moderate hypofractionation regimen, I think would be reasonable to use to treat the prostate for metastatic patients. They did separate patients with high metastatic burden or low metastatic burden. High metastatic burden is if you had 4 or more bone metastases with at least one outside of the vertebral bodies or pelvis, or if you have visceral metastasis to an organ. Now, my patient only had L2 metastasis, and so my patient will be considered low metastatic burden based on the STAMPEDE trial. And I think, as you know, in the long-term follow-up of this trial, now with 5 years, 61 months of follow-up, which is more than 5 years, patients with low metastatic burden had an overall survival benefit from prostate radiation. You can see the overall survival curve. Patients who got prostate radiation had much longer survival than patients who only got hormone therapy. The median survival was 63 months for systemic therapy versus 85 months when you add prostate radiation. So the median survival was extended by more than 20 months, which is almost 2 years of survival benefit from simple prostate radiation. 5-year survival was 53% for systemic therapy, up to 65% when you add radiation. So this is a really large overall survival benefit if you just treat the prostate with radiation. I think this is very strong evidence. And I also want to point out the hazard ratio for survival was 0.64. And the reason I'm showing that is because there is another trial called the HORAD trial, which asked a similar question. The HORAD trial was published 3 years ago. It's only 400 patients, but also patients, prostate cancer patients with bone metastasis, and also randomized to hormone therapy versus hormone therapy plus prostate radiation. So this also asks the question whether prostate radiation improves survival, but it's a much smaller trial, and I think this trial is actually underpowered, so not enough patients to really show a difference. But I think it's really interesting to know that when they look at the survival difference, they looked at patients with less than 5 metastases or more. So low metastatic burden would be this group of low metastasis. And actually, the survival of low metastasis, the hazard ratio is 0.68, which suggests a benefit from prostate radiation. So I actually think that these two trials have very similar results. So I think there's a very strong reason to treat the prostate in this case. I think there's strong randomized phase 3 data to show that RT to the prostate improves overall survival for patients with low metastatic burden. I think the findings from STAMPEDE with a hazard ratio of 0.64 and HORAD, which is underpowered but a similar hazard ratio, I think these actually two trials show very consistent results. And STAMPEDE also showed that prostate radiation did not compromise quality of life. So really not very high toxicity. So little toxicity improves survival. So I think that there's a very strong reason for this patient with low metastatic burden to treat prostate radiation. So that's my favorite option for this patient. I do think there's some reason to also treat the L2, and some people also chose option C to also treat the L2. And I think the reason to treat that is based on 2 phase 2 trials, STOMP and ORIOL. These are both similar trials. STOMP is 62 patients, patients with biochemical recurrence after primary prostate treatment, less than 3 metastases, randomized to observation or treat the metastasis with metastasis-directed therapy, either SBRT or surgery. ORIOL, also a small phase 2 randomized trial, similar, few metastases randomized to observation versus SBRT. And both of these small trials suggest a little bit of benefit from treating metastasis in these patients. And so STOMP showed that there was an improvement in ADT-free survival, which means that when you treat the metastasis, you can delay the patients needing hormone therapy. That was the benefit that STOMP showed. Delay in hormone therapy, not an improvement in survival, but delay in hormone therapy. And ORIOL showed that when you treat the metastasis, there's an improvement in progression-free survival. So you can delay the progression, but again, no survival benefit that was seen in these 2 small trials, but delaying hormone therapy and delaying progression may be enough benefit to consider treating L2 in these patients. Now, you can also see that in both of these trials, when you follow patients for a long time, there is a portion of patients, maybe 30% of patients, when you treat everything, when you treat the metastasis, you can have a long-term disease control for a portion of these patients. So maybe treating some of these patients, you'll have a portion that will not need any more therapy for a few years after. So my summary of these two trials is actually an update of these two trials combined that was published in JCO a few months ago. But these two phase 2 trials show that metastasis-directed therapy can lead to improved progression-free survival for these patients. When you had the long-term follow-up in the update, 15 to 20% of patients after metastasis-directed therapy achieved no progression for more than 4 years, even without hormone therapy. So some patients can really control the disease with MDT, and they can live pretty well without treatment for a long period of time. So maybe that is a possible benefit of patients. Maybe there is a small portion of patients who could be maybe cured with metastasis-directed therapy, or maybe metastasis therapy can allow hormone therapy to be stopped at some period of time, which also I think is a benefit of patients. So for me, aggressive treatment, including prostate RT and L2 SBRT, could be considered in select patients who want to be aggressive. I don't think there's a survival benefit shown yet, but maybe delaying ADT and long-term control could be considered. So I think in select patients, I would treat the prostate for everybody. For the metastasis, I would treat it in select patients and discuss that with the patient. So I think both B and C are reasonable options for this patient. So we'll move on to Dr. Wang's case, but before we do that, any questions on this case? If not, we'll pass it to Dr. Wang. Thank you.
OK，好。